Yeah, good evening. Welcome to this group discussion on abdominal wall reconstruction. Some of you who saw the link to uh, uh, the program, the Zoom program, might have thought it's a faculty lecture. But please note, for future reference, all my so-called lectures or presentations will be group discussions. So I expect all of you to come in, prepare.
Can sir recommend some textbooks, sir, so that we can prepare
All right.
when are doing a group discussion?
All right. I'll do it at the end.
Yes. No. Next topics.
Okay. Okay. I'll send you some links and things. Yeah. Okay. Right. So I think the world is taken by storm in the last 10 to 15 years by this enormous information on abdominal wall reconstruction. Okay, lots of conferences, lots of sessions, training programs, laparoscopic workshops, courses. The real sad part of the whole thing is that when I look for a literature, peer reviewed with what we consider is solid literature about, for example, RCTs comparing the formal AWR with the more conventional treatment. There are no RCTs that I could find. There are a few prospective studies, but most studies that you have in this field are retrospective studies, very small series. And so I think we should have an idea, at least those of us who really think that we should look at everything very dispassionately and objectively. We should try and get prospective, if not randomized, at least large prospective trials which show the value. Undoubtedly, there is value in it. Nobody says there's no value, but data are still not mature. That is the word people use. We don't have mature data on various things that are being recommended. And so one needs to, look at these things and analyze it objectively. The problem is very, very rampant. There is no doubt about it. With an increasing population of aged people, obesity, diabetes, and very importantly, survival from trauma. Major traumas, people survive. Big operations for cancer, people survive, which they didn't used to 20 years ago, for example. So because they survive, particularly with abdominal injuries and abdominal operations, you end up with large defects in the abdomen. And apart from dealing with the major organ injury, surgeons are left with this real problem of getting a proper closure, getting a proper abdominal wall closure. Okay. And so you find that even after simple simple laparotomy, incisional hernia can be anywhere between 5 and 40%. I think that is upper end. I think that's very high, but 20% is not surprising at all, 20-25%, particularly after cancer surgery. What is interesting is that the repair of a recurrent hernia, the recurrence rate of that operation is 2 to 3 times that of the primary operation. So if you have a laparotomy today and I repair it, suppose I'm an excellent surgeon and I get 5% recurrence. When you get the recurrence, you come back to me thinking I'm an excellent surgeon. So I do the repair again. I'm the same surgeon, but you'll find that I have a 15% recurrence rate. This is the truth all across the world. There is something that we don't understand completely, where recurrence rates are very high. And so this has to be conveyed to the patient every time you do the surgery as a part of your informed consent. Interestingly, it is higher after bowel surgery than after hepatobiliary surgery. That's almost understandable because the infection that one gets after the bowel surgery is really quite significant, and that may lead to the breakdown of the repair. So we come to the basic question. What is abdominal wall reconstruction? Nikita.
Sir, it usually means repair of the defect, which is beyond the normal repairs.
Like, what is a normal?
Sir, if there is a ventral hernia, we can repair it
Mhm.
But in case of large defects like incisional hernia, will require reconstruction.
Okay.
Yes.
So what is a large defect? I have an incisional hernia after a midline laparotomy, infraumbilical, 3 centimeters in diameter. I repair it. Does that become an abdominal wall reconstruction?
No, sir.
Now, what is it? Just a ventral
It's
hernia
an
repair.
abdominal wall repair. Yes,
Okay.
sir.
So when is it an AWR?
The defect has to be significant.
Okay.
Facial.
Please understand.
Loss of domain,
Yeah.
sir.
Sorry?
Loss of
That's one
domain.
of them. That's one of them. I agree. That's one of them.
And when there is an increased abdominal pressure because of reconstruction, so then the
No, that wouldn't come under that. You have to take measures to reduce the increased abdominal pressure. But the thing is, you have to not only restore the structure, when you do a ventral hernia repair for a 3 centimeter defect, you are restoring the structure. Okay. But what is more important is that you must restore the function. With a 3 centimeter defect, you don't even have a loss of function. The abdomen of the musculature works pretty well. And that's why it doesn't become an AWR. And another, there is no single definition, that's for sure. But this is the general consensus. And the other important thing is that there must be a closure of the fascia at the midline. Okay, you may have movement of muscles from the lateral parts, as you all know, and we're going to discuss today. But you must get a midline closure of the fascia with healthy facial structures rather than weak scar tissue. And many times you use a reinforcing mesh. Many times, sometimes you don't even need a mesh. That's not the main thing, but many times you use it because the fascia that you mobilize and suture in the midline, you feel may not be strong enough. And that's why you reinforce it with a mesh. But the important part of the definition means that you restore the function of the abdominal wall. Okay, that is something you remember. That's when there is, first of all, to restore it, you must have a loss of that function. So small ventral hernias do not have a loss of function. They do not come under the terminology AWR. It must be a big enough defect, loss of domain, as Vinod correctly said. And most of the time, that dimension of that hernia would be about 10 centimeters. It's not a sacrosanct number, but generally it is about 10 centimeters. That one brings us to the important question. What is the function of the abdominal wall? Vinod.
to prevent the abdominal contents to come out.
Correct. It has to contain the contents. Okay.
And to maintain the temperature inside.
Temperature, wall doesn't do it.
Regulate the intra-abdominal pressure, sir.
Yes, correct. Very good. Why would you want to regulate that?
Basically to assess in terms of breathing movements and
Okay.
so to ensure proper diaphragmatic movement and
All right.
again then it
Urination,
will provide
defecation.
protect the
Very,
internal
very
organs.
correct. Very correct. The two main functions are the first two here: contain the viscera and support the spine. None of us think of it. None of it think of the abdominal wall as supporting spine. If you do not have a proper structure and function of the abdominal wall with enough power to generate to contract and have that power, the spine is bent forwards and nothing holding it. So imagine when you talk about core muscle, this is what I keep saying. We all do core muscle exercises every day. Particularly with aging, it is highly recommended that you do core muscle. The core training, which I do every day, for example, involves a lot of abdominal wall straining, head raising, leg raising, and lots of other things called, gluteal pushes. And all this, makes the abdominal wall exercise, just like you running or walking does your lower limbs. Okay, you must have good abdominal muscles to have core strength. Very important. Generate Valsalva. This is what Ines said. You need to increase intra-abdominal pressure. Okay, to urinate, to defecate. Okay, all that is important. There's one thought, not completely evidence-based, but a thought that without intra-abdominal pressure and good abdominal muscles, you do not have satiety. And if you do not have satiety, you eat more, and become more obese and make the condition worse. So it's good to have a good abdominal wall power, as it were, strength, as it were, to have good weight control as well. These are the four main functions of the abdominal wall. And in a large ventral hernia, these are lost. And so it's good to have to reconstruct it. That's when the word AWR comes into being. The philosophy is very simple. Whenever you do your large hernias, you must understand that the abdominal wall is a dynamic structure. It's not some sitting there, a sheet of muscle sitting there. It's dynamic. It's working all the time. When you have scar tissue because of this hernia, your dynamism is lost. And so you need to get rid of the scar tissue, get good fascia, do things to the muscle which come back or restore their function. Linea alba is like a tendon injury. All right. So a proper suture, tendons are, as you know, relatively avascular, and so they don't heal very well. So whatever you do with the linea alba must have proper support, takes the form of non-absorbable or delayed absorbable sutures, lack of tension, and reinforcement with meshes. And the tension-free that we talk about, that's the lack of tension, has now, the terminology has slightly changed to bring in physiological tension. What is the context of this? If you have no manipulation or surgical intervention in the lateral abdominal walls, put a big mesh in the central line, there is no tension, but it is not physiological because the muscles are not working. So the muscles have to work in conjunction with your prosthetic material and then restore the function. So that is the word they use. So all these concepts, philosophies put together form abdominal wall reconstruction. So as I said, the small little hernias that you get do not give you big defects, and the term AWR need not be considered here. But what are the things that give you large defects? All right, go ahead, Samir.
Sir, wound infection
Okay, very good.
and any prior surgeries to the abdomen itself.
Yeah, I mean, surgery would be wound infection. That's when you get the wound infection. You do a laparotomy and you get a bad wound infection, which can cause a lot of havoc. It can cause necrosis of muscle, fascia, and all that. Septic
Yes.
necrosis, you end up with a large defect. What else can make you end up with a large defect?
Nutrition, sir, malnutrition.
That's again, cause is infection. Okay. Most common causes are abdominal wall tumors. They may be either benign or malignant. All right. So what is a benign tumor that can give you a large defect? Sorry?
Desmoid tumor.
Yes, correct. And you may have large malignant tumors, rhabdomyosarcomas, major laparotomies. Aneurysm repair is considered one of the big risk factors. As I said, cancer surgery, major resections. Basically, because they are immunocompromised, you may end up with a large incision, and there may be infiltration to the abdominal wall, which may necessitate wide resection of the abdominal wall itself. And of course, trauma with infection. Sometimes trauma with bowel injury, for example, when you close the abdomen or whatever, you may end up with bad infection, bad fasciitis, which gives you a huge defect. And previous hernia repair. Each time you take away the unhealthy scar tissue and put another mesh, perhaps there is an inherent problem with the collagen in the patient, then, or it may get infected or whatever, get a complication, hematoma, infection. You end up with another bigger defect and a bigger defect. And so the second or third time you go in, you end up with a bigger problem. So these are the major causes of big defects which necessitate abdominal wall reconstruction. These are some of the examples of my cases that I have shown you. Look at this big desmoid here, in the right lower quadrant. We excise that, you end up with a big defect. Okay, my hand is covering half the defect here. Okay, and end up with a tumor like this, which is 6 inches big. You can see normal muscle around. And just for interest, you see these threads here. What is it for, Vinod? You see the silk threads
Yes, sir. To know which is anterior, which is posterior, and
correct orientation. It's a very important thing to put orientation on all these surgical specimens to help the pathologist define clear margins. Good. That is the reason for it. So we come to the anatomy. I'm not going to touch on it for long, but we all know about the rectus abdominis, the linea alba, and the 3 layers of muscles. And I put this picture up deliberately, okay, to highlight the fact that there is a defect in this picture. So I would like, maybe Nitya, there is a defect in the representation of this picture. It's on the net and I've taken it from there. This is the cross section. We all know about the lack of posterior sheath below the
Yes, sir.
arcuate line. What is the defect in this?
Sir, in the first picture, the one in the above,
Mhm.
the rectus muscle is not completely covered by the. There should be fusion of the.
It is there. This is the anterior sheath. They have not shown a green one, but this is the anterior part. Okay. So it is
Yes, sir.
that is supposed to be the anterior rectus sheath. That is covered. The internal of the green one is the internal oblique, which is split into 2.
Yes, sir.
And above the arcuate line, of course, it's split into 2. Below the arcuate line, there is no
Then
posterior
it's the
sheath.
posterior. Below the arcuate line, there is no
No
posterior
posterior
sheath.
sheath. Yeah, that is shown all right. But what is the problem? Focus on the
Transversalis fascia, sir.
go on. Tell me, Nikita, what do you think is the problem there?
It is supposed to be above the transverse abdominis muscle.
It is above the abdomen, transverse fascia. It is above
No,
the
sir.
abdomen.
Here they are indicating it beneath, sir.
No, this is a transverse section. Transversalis fascia is not above the transversalis muscle. I mean, in the sense, it is deep to the transversalis muscle, right? It cannot be above. It's extra peritoneal. Next to the peritoneum is the transversalis fascia, and next to that, more superficial to that, is the transversalis muscle. The important thing is this representation where the transversalis muscle stops here is incorrect. Okay? Can you see my pointer?
Yes, sir.
Yeah.
Yes, sir.
The transversalis muscle extends right up to this point, where it actually extends maybe half a centimeter or 1 centimeter, not half, 1 centimeter, medial to the linea semilunaris. This is the linea semilunaris, where the lateral muscles split and join to form the rectus sheath. So the muscle itself here extends. It has a very significant surgical importance. That's why I'm saying this. This actually should have been shown up to this point. Later on in the presentation, I'll show you a picture which is a correct representation. So bear this in mind. Okay?
Yes,
All right.
Yes.
So the infection risk is something that people talk about. Everything gets a kind of a classification and a gradation. And it really is a strain on surgeons and students. But in this particular instance, it is a practical gradation that has been put up by the ventral hernia group. And it is significant because particularly significant when you are thinking about recurrence in a recurrent hernia. Okay, when you are repairing a recurrent hernia. So they recognize 4 potential grades of infection. And the worst case scenario is the infected mesh. Okay, you end up getting a recurrence in a hernia, or an infected mesh where you have to do explantation. And that is the worst case. And they have the highest recurrence rates of incisional hernia repair. The lowest one is no complications, no history of wound infection, but has a big defect. So please bear that in mind. And these 2 are in between. This is significant in terms of conveying the risk of recurrence to the patient. So whenever we talk about hernia, we said not only do we get a midline closure, but also a prosthetic material. Prosthetic material need not necessarily be synthetic material. So what are the things that you know of? Vinod. No, Praveen, I have not spoken to Praveen at all. Praveen, what are the things that you know of?
Hello, sir.
Yeah, go on.
Sir, regarding mesh, sir.
Yeah, not necessarily a prosthetic material. Go on, mesh. Tell me mesh itself.
Sir, it might be of biological and synthetic one.
Okay.
So, biological has less infection.
Mm-hmm.
And
how many biological meshes have
and
you used?
No, sir, we are not using, no, sir.
Then I keep on telling you, mention the ones that are most common, most commonly used, most commonly prevalent. Make it a habit.
Yes, sir.
What is the commonest
Synthetic
mesh
are the
that you
most common.
use? Ah.
Synthetic
In
meshes
that,
are the
in
most
that, what is
common
it?
ones used, sir.
In that, what is the most common that you use?
Polypropylene mesh.
Correct. What else do you use? Okay.
And
When skin can be approximated, okay, that's an important thing. When there's a big skin defect, you have to use something else. Without skin closure, you don't want to put prosthetic materials in the depths. Okay, even a free non-vascularized facial lata, for example, can be used. Polypropylene is the most common, and mesh is a whole topic by itself. But for AWR, in that context, the best thing is to use a large pore, lightweight mesh. That's something that you have to understand and use it. We do this all the time because it is strong, it is cost effective. But people take an exception to the intraperitoneal placement everywhere. There is no evidence for it. I'm not at all defensive when I say we can use it freely. Objection, whatever is raised, is anecdotal, and it has actually been mentioned in references to that effect. But when we talk in conferences, when we talk amongst ourselves, we talk as if there is huge evidence that intraperitoneal proline or polypropylene should not be used. That is clearly incorrect. Ravi, you want to say something?
Yes, sir. Few things. One, I agree with you totally that I have actually, I think I and you are, we very strongly, vehemently, I think people make flippant remarks about legal aspects of it. I have never seen a single legal case where somebody has been implicated because they use a proline mesh.
Right.
And there are any number of patients who have been, who have had operation with composite meshes, which in the operating sessions have shown, explantation of mesh with bowel resection because of fistula and severe infection. So I think that your meta-analysis also has already been quoted many times about the, there is no difference between the two meshes in the form of either fistulation or intestinal obstruction or bowel, such like. The
Yep.
other thing is, I think I sent you that, just before the Bangalore State Conference, because I was defending the, against AWR. I, went through quite extensive literature search, and there was a consensus, about 40 pages of consensus document, which I think I sent it to you also, and
You
I sent it
did?
to everybody,
Yes, you did.
where the only level 2 evidence is for IPOM plus repair using a proline mesh.
Yeah.
So all others are level 3, level 4. That was 2021-22. I think that there is not much has changed in 2021-22. I agree with you totally that all these conferences talk about all these repairs in very glowing terms, but none of them have any evidence base to show with it. And significant infection rates, seroma rates, and then recurrences up to, as you said, up to 40%, even with any of these major AWRs, has been documented in majority of the series.
Correct.
And
Very good.
and the other one thing which I wanted to tell you was the reason for IPOM being converted to IPOM plus was what you quoted about the function of the abdominal wall, the spinal support. Apparently, the spinal support is better if you close the defect, which we wouldn't do before, and I have started doing it. I don't know whether how we can quantify that the patient is better, but that was the reason quoted for the IPOM plus being converted to IPOM. IPOM being converted to IPOM plus.
Right. I have two comments about this particular aspect, which I'll come to when I show you subsequently, because I had slides on this issue. So this is, composite meshes and polytetrafluoroethylene PTFE. These are the other meshes that are commonly used. Biological meshes have their own role, but we need to learn a little bit more about it.
Sir,
So,
can I just
yeah.
ask you? See, I have the issue with polytetrafluoroethylene. It doesn't actually integrate well with the tissues.
Yeah.
The ones which I have seen others use, and I've had to go back to repair recurrences. I see absolutely no evidence of any healing at all. I don't know how PTFE has, still it is still mentioned as the one of the material for prosthetic meshes.
Yeah, that's true.
They are using along with the combination, sir, because to
It's a composite
just like
mesh. One
yes,
side
sir.
it is polypropylene, other side it's PTFE. I agree, but all this is actually unnecessary in my view, and that's why I have never used them at all. So, Sanya, you're there. I didn't see if you're there. Yeah, if you're
Yes,
there,
sir.
talk to me about biologic meshes. We'll have to include the registrars also. Yeah, go on.
Uh, so,
What do you know about it?
yes, sir. They're usually these meshes that are made out of biological materials, which could be
Like,
derived either from the bovine tissue or porcine
correct,
tissue,
porcine, bovine, or
bovine
human.
or human
Yeah.
also.
What
Yes,
do
sir.
they use? What do they use? What is the term for it? What do they use? Acellular dermis.
Yes, sir. Yes.
Acellular
Acellular
dermis.
dermis.
Okay.
Yes, sir.
So what are its qualities? What are its purported advantages and disadvantages?
Sir,
Okay. It's good in infected fields. Okay. So the worsening of infection doesn't occur when you do an infected hernia, for example, but there are higher recurrence rates, really higher infection rates. The important thing is, even if it gets infected, you need not explant it because the foreign material, that is the acellular dermis, would not cause the kind of problem that a synthetic mesh would cause. So if you have a biologic mesh or even a fascia lata, for example, which is bridging that gap in your in the muscle, then you need not explant it. But as I said, recurrence rates are higher, 20% versus 5% as compared to synthetic meshes. And the other advantage is that you can have radiation therapy as well, unlike in infected synthetic meshes. Okay, so if you're giving cancer, giving cancer treatment, biologic mesh can be considered, but it's extremely expensive. 3 to 4 lakhs sometimes if you want a large mesh, and I have never ever used it. Okay, because I've always, even in infected cases where I cannot use a synthetic mesh, I have managed to bridge the gap with component separation, which we'll talk about later. Okay, this is a personal rambling on, if you can call it that. And this is where I have to make one observation about what Ravi said, and we'll have a little discussion on it afterwards. See, the mesh was introduced into hernia surgery because of a tension-free repair. If you do an anatomical repair, your recurrence rate is 30-40%. If you do a mesh repair, the recurrence rate is in the single figures, 5 to 8%. Okay, and the defect was not closed, that would give tension, but bridged. Fair enough. Then when we came to laparoscopy, this was done, with great impunity and with great freedom in open surgery days. When it came to laparoscopy, the same bridging was done, but there was a bogey of intraperitoneal proline, polypropylene. We have mentioned about it, and so they started using, without much evidence, these expensive meshes and the composite meshes and the PTFEs and the like. Okay, with small defects where they were not keen on using, not closing the defect. IPOM plus, for example, the smaller defects, their worry was seroma. But in actual fact, in the practice that we have, where we put a little plug into that area of the defect and leave that for 10 days, there is practically no seroma. We in fact have long-term, 10-year-long follow-up on these patients, and no hernia, no recurrence, no nothing. Okay, and this is where Ravi's point has to be taken in. If it's a large defect, for example, that's when in a small defect, the spine function is not affected. In a large defect, there are two problems with approximation. One is that you cannot approximate them because there is a big tension there. And second, even if you approximate the fascia, you're left with a bigger bump on the skin, and they perhaps have to do some kind of a skin cutting procedure to make it cosmetically acceptable, but otherwise that bump would be unacceptable. In which case, you end up with a cut and pain again. The advantage of laparoscopy is gone. Okay, that was the contention that I had in terms of IPOM plus for large defects. Okay, and the other important thing is that it beats the tension-free rule. The idea was that you would not approximate these large defects because they would fall apart. So you should bring in, rather than an IPOM plus, you should bring in a component separation. And on top of it now, after having said all this and we have used composite meshes for 2 to 3 decades, 2 decades. And now they say, no, it's no good. Don't put even a composite mesh there. There is this problem and that problem. And now they're pushing ETEP. Okay. And now they say, okay, ETEP, not only should you avoid the intraperitoneal mesh, IPOM or IPOM plus, but it gives you less pain and you don't have to use stackers and save money on it. These are the 2 things that are said. All said, and the less pain is yet to be well established. Data is not mature on it. But if you don't use stackers, you perhaps save some money, but you're spending so much more time on your operation doing the ETEP that the overall cost of the operation will be higher. Now, the reason I put all this up is to bring awareness to our youngsters, our postgraduates, to classically understand that various concepts come in waves, and it is the responsibility of us surgeons. You're all surgeons or going to be consultants. It is the responsibility of all of us to not blindly swallow what so-called experts say, but to sit down and analyze. And in that analysis, if you really think that some method is good, please go ahead with it. If you think there is some doubt, wait until the data matures. Floor is Ravi's to talk about IPOM plus. Ravi, are you there?
The one thing I wanted to talk about this composite meshes, that they quote that there is a sepra film on one side which prevents adhesions and hence prevents the fistulation and the complications thereof. I was working with a surgeon called Malcolm Wilson, who was in the South Manchester University Hospital. He conducted a nationwide study of sepra film being used, for post, in the intraoperatively to prevent adhesions, and also the liquid form of it called the adept liquid solution, which used to be instilled as a liter or so to prevent adhesions, and they conclusively proved that it doesn't, work. So sepra film, using it as a part of the composite mesh, I don't think there is any evidence for that. I as I said, the evidence for IPOM plus is still, I don't know how you can actually show that, I don't think there is any study which has said the stability of the spine was this before, doing this and then after. So I think it is just a theory that, because we know that the abdominal wall strength is necessary for the stability of the spine, it sort of makes sense to actually close it so that it affords the stability again. But I don't think there is any evidence for that. I agree with you with a lot of things that if you are, closing a very wide defect, then basically it is in under tension, so it does defeat the purpose of tension-free repair. But what I do is make a small incision in the abdominal wall where the hernia is, and then on the outside do a near far repair which is not under very much tension and the incision is not big, and I do the same thing as you do, put a gauze there and pack it, and to prevent it from causing seroma. Anyway, we excise the sac as well at the same time, so that definitely reduces the incidence of seroma. So that is what I do, but I think there is very little evidence to definitely suggest that it has made a significant difference.
So the postgraduates must also remember that there is another class of meshes called the biosynthetic mesh. It is a monomer, butyrate monomer, one of the common ones derived from the E. coli, and it's a delayed absorbable mesh that can be used in infection. We also have the polyglactin or the Vicryl mesh and the polyglycolic acid meshes. This is Dexon and Vicryl meshes. They are the trade names. These can also be used if you're worried about an infection in the wound. But I do believe that when there is real fear of infection, one must have the expertise to do a good component separation And you can do hernia repairs, even big defects, beyond 10 centimeter gap as well. Okay, you can do them with component separation and without a mesh. Okay. Now, there's also a concept of mesh sutures. I don't know how many of you have heard of it. I read about it just about a couple of years ago. I have not used it, but they use two terms to describe the importance of the so-called mesh sutures. One of them is showing that ultimate tissue strength is higher. This is tensile strength of the repair, and better STI, that is a suture tissue interface. This is basically common sense. It's a big sounding word, but basically if you have a single suture like number 1 or number 2 nylon or whatever that 10 nylon, it's thin and it can cause necrosis when there is pressure, and it can cause cutting through, cheese wiring. Whereas the mesh suture is a 1 or 2 centimeter strip, which is loaded onto a needle, as it were. And so you pull the whole mesh, a 1 centimeter wide mesh, as a suture, and do your lattice work of bridging the gap. And so they say that if you do a lattice like that, instead of using a full mesh, the overall mesh material is less. They claim it can also be used in infected cases. I have no strong data to prove this, and some of them claim the early results are promising. I have never used it, but I can't believe that this is true. You also use it in infected cases, because even though the amount of mesh material you leave behind after the repair is less than in a standard full mesh, the overall nature of the mesh material, where the bacteria cling on to the mesh and cause persistence, that risk remains. And so we really need to look at long-term data before we adopt this. But I just wanted you to be aware of the concept of mesh sutures rather than our conventional sutures. Okay, the important thing that we talk about is loss of domain. So Vinod knows about it. Go ahead, Vinod. Tell me about loss of domain.
Basically, loss of domain means when the visceral components more than 20 to 25% is outside the abdomen, then we'll call as generally loss of domain.
Correct. So what are its consequences?
That leads again when we are doing a procedure that may lead to increased abdominal tension, and we cannot
after the procedure.
Yes, sir.
Yeah. Okay. So this applies to large defects. Usually the defect is more than 10 centimeters. There is no single definition of loss of domain. There are 6 different definitions. Some considered volumes, some considered the distance of separation of the rectus. But what is called the Tanaka method, measured on a CT, you have to have a CT before you can make this measurement, is probably the most widely applied. Okay, and this is the method. There is a Tanaka method and a Sabag method. And if this is the hernia sitting here, it is outside. This is the peritoneal cavity. This is the hernial cavity. In the Sabag method, okay, they have a hernial sac cavity. The denominator is not only the abdominal cavity, but abdominal plus hernial sac cavity. Okay, and so if it is less than 20%, then there's a loss of domain. It's more than 20%, sorry. In the Tanaka method, the denominator is only the peritoneal cavity here, okay, only this bit, and not the whole thing. And there the denominator is 80, and so it should be 25%, as they say. And this is pretty straightforward. When you have a CT scan, you can see what the measure. You can measure the volume, volume just by length versus the height or the breadth, and you get these figures. Very simple. There's another parameter, as I said, it can also be with distances, not just volumes. It's called the rectus to defect ratio, RDR, or the Corbinell ratio. Any of you heard of it?
Yes, sir. We have heard it in the FIAGS
All right.
the talk, sir.
What is it? What was it?
So
Tell me what
the
it is.
ratio of the
Sir,
sum of,
Okay,
yes, sir,
so
width of
this is
right
what
and
it
left
is.
axis and
Okay,
maximum defect.
so you
Yes,
do a
sir.
CT again, look at the length or the breadth of the rectus here, this bit and this bit, look at the defect size. Okay, you calculate the total of that, and you take a ratio, width of the rectus, right and left rectus put together, divided by the width, maximum width defect. If the ratio is less than 1.5, they need component separation. You're not going to get them right. That's when component separation essentially is one form of AWR. So they need component separation. Okay, this is the RDR or the Carbonell ratio. I'm not going into details of it. All of you know this. We need some correct nomenclature for the kind of hernia that we're dealing with, which should include the location, the size of the defect, whether it is recurrent or not. And the current EHS classification satisfies that. So that we must have an endeavor, every hernia that we do, we must try and apply the EHS classification so that at the end of 2 years or 3 years, you can have a retrospective analysis of how your patients were doing. The important thing, again, that they stress is that if you have multiple holes, the confusion occurs. Should we have the dimensions of the biggest defect as the defect of the hernia? The answer is no. You must add up all of them. The total length and the total width of all the defects put together. That seems to give you a better idea of what the size of the hernia is rather than the dimensions of the largest defect. Okay, so midline hernias, lateral hernias, multiple hernias. All these things are addressed in the EHS classification, and you must understand them. But this, for the whole talk, this is my learning actually as I was preparing to this talk, for this talk. This is what we must expect from our radiologists, which we don't get. So the job for Sanya and Nitya is to take this slide. Okay, I can send you my presentation. Go and talk to our radiologist and say, sir, this is the kind of information we would like on our CTs of incisional hernias, so that we can have studies as we go along later on in our in the progress of the departmental work. Okay, so it must have the wall defect, it must have the location, the defect size, length and width, the RDR, LOD regarding the Tanaka, usually using the Tanaka method. Let us fix on the Tanaka method, and subjective impression of the muscle quality, both of the rectus and the abdominal muscles. These come into play when you're talking about the functional restoration and any complications that may be there, infected mesh, bowel obstruction or whatever. Okay, please understand that. And if you don't get a radiology report, you can't expect every radiologist to give you this report. When you see the CT yourself, I think we must make a note of this in the patient's record. These are the findings that I have of all these aspects of an incisional hernia. I think this is a beautiful slide, and please note this link also. Very, very nicely, one big page of web page of information on radiology of an incisional hernia. Lovely, lovely site, and I would recommend that to you. Okay, so I asked you what are the consequences of loss of domain. First, you must understand the pathophysiology. What happens? Because this is important for you when you're planning restoration. There is fibrosis. Instead of muscle, there is fibrosis. Weakness, always. It has no strength. Lateral displacement of rectus abdominis. There is a disuse atrophy because they're not working. Because for effective working of your abdominal muscle, there must be midline approximation. That is not there, then there's an issue. And you find that because they're not working well, the muscles are stiffer and less elastic. And so there's a vicious circle, as it were, vicious cycle, as it were, of getting worse with time. So it's important that if you want to restore the function, that you intervene, get the patient to get the surgery done in reasonable time. If you leave it for years just because they don't have obstruction or strangulation, your results of surgery may not be very good. So what are the consequences of loss of domain? Nikita.
Sir, post-surgery, there'll be tension.
Pre-surgery, what are the consequences? I'm not talking about post-op, pre-op. In other words, why do you want to operate on these patients? There may be surgical
The
challenges.
function of the abdominal wall will be impaired, sir.
Okay.
Whatever the previous functions you had told, defecation,
Correct.
urination, and
Correct.
Valsalva.
Correct.
And
They'll have back problems. You mentioned that also.
yes, sir.
Okay. So in addition to that, okay, they'll have a descent of the diaphragm and so respiratory issues. They'll have respiratory, they cannot, because there is nothing for the diaphragm to work against, they cannot cough well, they cannot generate the amount of negative pressure that they need to have good breathing. There is portal venous stasis, okay, because of this loss of domain, they get bowel edema. So sometimes reducing these thickened bowel back into the abdominal cavity can be an issue. And with same bowel congestion also occurs because of the portal pressure being high in these patients. They may end up with pain and diarrhea. So they actually have GI dysfunction. May not be very, very evident, but it will be marginal. So they have GI dysfunction, they have respiratory issues, and they have back issues. So loss of domain is not an innocuous phenomenon. Okay. So this is a kind of experience. Look at the amount of scar she has had from previous surgery. Okay. She has had a laparotomy and 2 hernias being repaired before I saw her again. The classic CT. Please note that this is the rectus on this side. Okay. These are the lateral muscles, the 3 layers of lateral muscles. Here, I can hardly see the rectus. There is nothing from here. Practically, this is all unhealthy scar tissue, and you see only 3 muscles. This is the rectus, I presume, but nowhere near the kind of bulk that this has. And the whole thing from here to here is the defect. From here to here is the defect. This was a patient who needed a very big transversus abdominis release, and in spite of it, I couldn't get a midline approximation of the fascia. We managed with a mesh, and she's doing well, and with only partial restoration of her abdominal wall function. The other important point that I made about is an infected mesh, and when you take it out, as we have done in this case, there's a huge defect. Again, a big challenge for you to bridge or correct. And oncological excision. This is a patient with an incisional hernia after a colectomy. Look at the degree of adhesions of the bowel and the defect from here to here. The whole thing was a rectus defect. Again, settled with component separation. So the indication for surgery, is a bit of a repetition of what we have said earlier. It's prevent loss of domain consequences, prevent obstruction and strangulation, and to get some kind of a reasonable cosmetic result. Okay. So what are the contraindications? When would you not operate, even though we know that there is a consequence for loss of domain? Go on.
When there is an infection.
Sorry, active infection.
And patient is not fit for surgery.
Okay. Big time comorbidity, agreed?
Yes, sir.
Okay. Coagulopathy, very important. And if somebody has uncontrolled diabetes or morbid obesity, these are big risk factors for surgery. So you have to think about doing it. None of them is an absolute contraindication. These are all relative contraindications. You have to have a risk-benefit ratio assessment, and in your judgment, good, honest judgment, if you think it's worth taking the risk, then even with these conditions, you can go ahead with the surgery. People have written a lot about it. Okay, please note that AWR is now come under, a lot of plastic surgeons' domain. I saw a lot of papers in plastic surgery about this. And they say, this is a plastic surgeon talking. These are the things, they're all common sense, but I'm just reiterating it so that all of us as surgeons bear this in mind before we embark on this fairly serious, high magnitude surgery. Optimization, cessation of tobacco. What is the minimum period of cessation of smoking?
30 days.
30 days, correct. That gives you benefit. Correct the malnutrition. Okay. Obesity is also a kind of malnutrition, diabetes. These are just principles which we follow all the time, which we don't forget. Switch a good fascia to good fascia. If necessary, reinforce it with a mesh. Always bear in mind the possibility of cheese wiring and abdominal compartment syndrome. What is the correct mesh? People say that we have discussed it before. We believe that polypropylene is as correct as anything else. The best position, if you're putting a mesh, if possible, is a sublay. That doesn't mean that an onlay is completely ruled out. It is not. There are situations where onlay has to be done. And good to have a 5 centimeter overlap. No strong evidence, but that has been the consensus. You must give attention to skin and subcutaneous tissue. When you're doing the component separation, you are undermining the skin to a large extent to get access to certain areas of lateral muscles, and you can cause ischemia of these muscles, end up with skin necrosis. And so it's important to preserve the peri-umbilical perforators, the area around 3 to 4 centimeters on either side of the umbilicus, are where the perforators come up from the muscular branches and supply the skin. So you must have an idea on it. You must have an idea about where they come and preserve them. One of the things is that instead of undermining from, say, the midline area to the lateral aspect of the linea semilunaris, don't touch the skin at all. Let it be there. But you can make a small hole in the lateral abdominal wall, anterior line, lateral to the linea semilunaris, and then use a telescope and see the MIS. With an MIS being done more and more frequently now. I haven't done it yet, but I think it's easy enough to do. Then cut the external oblique. Far away, you've got an anterior component separation, but without compromising the blood supply. That's an important thing. And in the post-op care, always bear in mind DVT, pulmonary complications, and abdominal compartment syndrome. These are the 3 main things that you should focus on. Okay, the workup is routine bloods, workup for comorbidities, always focus on DVT prophylaxis. Ultrasound to look at other abdominal problems, including gallstones and something or possible obstruction. Definitely CT. I don't think we should go to AWR without a CT. And as I said, focus on all the aspects that I mentioned about when you see the CT. Okay, what are the goals of treatment? Broad goals. Praveen.
Sir, said functions to be restored, sir.
Okay, very good. Anatomy to be restored.
Yes, sir.
Okay, all right.
Anatomy.
Very good. Yeah. Okay, structure and function to be restored. Provide stable skin cover. It's very important that skin is important, as important as the fascia. Prevent recurrence. Recurrence, as we said, is between 15 and 40%. Avoid the bowel obstruction and fistulation. So to some extent, you will need to have adhesiolysis when you're doing these operations. You can't just focus on the abdominal muscles. If there are very bad visceral adhesions, you may have to release it, knowing that some of them may return. But if you have bad kings and bands, which can cause a volvulus around them, those have to be definitely dealt with. And of course, cost measures. The aim is to obtain a tension-free midline, healthy facial approximation with a reinforcement using a prosthetic material. I'm repeating what I said in the beginning, and that is just to reinforce the thought in your mind. Okay.
If skin cover cannot be provided, can you use a graft?
Yes, there's a slide on that. Okay, we'll be talking to you about it. It's an important question. Yeah. So, as I said, ACS is a real issue, and if you have a loss of domain, you must expand the abdominal cavity to accommodate whatever viscous bowel is extraperitoneal in the hernia. So you have 2 main methods. One of them is to use progressive pneumoperitoneum. The other one is to use the Botox. Okay. This is a study that I picked up, a recent study. You find that, it's quite effective in doing it. 50 patients, they used an intraperitoneal catheter and put about half to 1 liter every day for 2 to 3 weeks. I usually use it for 10 days, which is usually good enough. Done as an outpatient, we put a liter every day. They they attained a total of 5 to 16 liters of insufflation. We gain, we put in about 15 to 20 liters, push it in until the patient has discomfort. And, 2 patients with COPD had respiratory issues. Many of them had subcutaneous emphysema. I've had none whatsoever so far. I haven't done 50 patients. I must have done about 8 or 10 patients. I have not documented them. But I don't think we have had any major problems. So it works well. It works well. No two ways about it. Botox, very expensive. So I don't use it. But you can give a shot in the anterior axillary line. This particular study, they gave 600 units, diluted it, and made it into 6 equal injections. 3 injections on each side, into each of the layers of muscles. 1 into transversus, 1 into internal oblique, 1 into external oblique. Ultrasound guided. They use that to guide the depth of their needle. And they found that at the end of 3 to 6 weeks, they waited a minimum of 3 weeks and a maximum of 6 weeks. The abdominal transverse diameter increases, anteroposterior diameter decreases. The abdominal muscles thin out because they're not working, but psoas becomes thicker. That seems to compensate for the abdominal muscles becoming thinner. And definitely the patients with loss of domain have a higher impact. So they have a much better, ovalization, if you want to call it that, of the abdomen compared to those without LOD on the actual measurements. So bridging large skin defects, we come to the question raised by Shrikant. For lack of time, I think I'll just go through rather than ask questions. It's easier that way. Bridging large skin defects can be a problem. You need the help of a plastic surgeon in that. So you can use tissue expansion. You can put a tissue expander and get the skin to stretch and put it in there. You can use grafting. Okay. You can use graft even on a mesh, for example. If there's some granulation sitting on it, it's a temporary graft. It may not take permanently, but you can use it. But the most common and the most effective method to bridge a skin defect is to get a myocutaneous flap. You can use a rectus from the opposite side if it's available, or you can take a tensor fasciae flap and do it. And definitely you need a plastic surgeon's help for that. Bridging large facial gaps. What I said previously was the skin gaps in facial gaps. Okay. If you can use a large mesh and close the gap. Okay. But that does not change the biomechanics. It does not change the function. So it's not recommended. In addition, you have a large mesh, you have perhaps a higher incidence of mesh complications. So the thing to do is component separation. It restores the function. It gives you better healing because you're taking away the unhealthy scar and putting only healthy fascia together. And definitely proven in surgery, in studies, to have less recurrence. But it is technically demanding. And as I mentioned, if you do particularly anterior component separation, if you do a lot of undermining of the skin, vascularity of the skin can be affected. So just be careful, don't undermine so much, or use the minimally invasive method to do the anterior component separation. If you do that, you will obviate this. And of course, as I mentioned in one of the cases that I showed, if even after component separation, you cannot approximate in the midline, have a combination of the two. Use a mesh to do it, but get as much component separation as possible so that if not great functional restoration, at least there is partial functional restoration. And that will benefit this patient in terms of excursion of the diaphragm, bodily functions in the Valsalva maneuver, and support to the spine, as we mentioned earlier. Okay. And this is when you, as I mentioned, when you have considered about vascularity, consider a subcostal incision and that subcutaneous tunneling with a telescope, with a laparoscope, and do it that way. And preserve periumbilical perforates. I've already mentioned that even if you undermine the skin, don't do it in the periumbilical area. You can go a little more higher above and below the periumbilical area and still undermine to some extent and get it without compromising the skin supply. The mesh can be placed in any of these positions after your component separation. Okay, the sublay meshes are the best. Sublay itself has three separate locations, as it were: retromuscular, preperitoneal, and there's an alternate configuration for the preperitoneal and intraperitoneal. Intraperitoneal is not normally done. When you have done an effective component separation, you do not need an intraperitoneal location for your mesh. What is, as I said, while sublay is a preferred method, onlay is not ruled out, and that is required when you do an anterior component separation. You are not going to the posterior areas, so you do not get approximation. So after you do the anterior component separation and fix the fascia in the midline, you have to put an onlay mesh to reinforce it. While it is not the best, it is quite acceptable. The simplest, without having to do anything, if you do not have a very large defect of the linea alba, is to do this. Do two relaxing lateral incisions from top to bottom, as it were, and cut through the muscle, the anterior muscles only, the anterior muscles, and approximate the midline and close it. As you can see, we have retained the bridge. The periumbilical arteries come here. You have retained that bridge and you will not get skin necrosis. This defect may either be closed with a secondary suturing after the initial thing, or if this remains pretty large, you may put a split thickness graft to close this defect. Okay, in this particular patient, as it happened, when the edema decreased and the abdomen flattened, we managed to get a primary closure of this with a little bit of undermining of these skin edges 2 weeks after the surgery. Now, I told you about the defect of the picture that was shown earlier. This is the anterior component separation. You have a rectus here. Please note, this is the correct demonstration of the internal of the transversus abdominis. The anterior external oblique comes there. Internal oblique splits on either side. The transversus abdominis, if you remember, that picture showed the muscle stopping at the same level as the internal oblique and the external oblique. That's not correct. The muscle extends right down here. Perhaps they've shown too large a distance on the posterior wall. Maybe it'll be somewhere around here. So its importance I'll tell you in the next slide. Here I'm showing the anterior component separation where the external oblique is divided right from the costal margin right down to the suprapubic area. Unless the defect is much smaller, when you don't need such a long one, you have to tailor it to the distance between the two recti muscles. So then undermine this a little bit. When you do the shift this, and when you separate this tissue here between the external oblique and the internal oblique, this part moves medially and you get a midline approximation. Okay. Note that the neurovascular bundle is between the internal oblique and the transversus abdominis, and it comes through and supplies the rectus just at this bifurcation, just at the bifurcation of the internal oblique abdominis, which is a linea semilunaris. So if you want to cut the posterior sheath, which you have to for posterior component separation, I think the title here is wrong. It should have been posterior and did I interchange it? No. Yeah, I should have. This is posterior. Please, my apologies for this error. This should read posterior. So if you are cutting the posterior sheath and the transversus abdominis muscle here to move the rectus medially, it has to be at least 1 centimeter away from the linea semilunaris. If you cut it at the linea semilunaris, for example, you may denervate the rectus muscle, which becomes weak and beats the purpose. Then you may have a higher recurrence of hernia. So you have to cut it at least 1 centimeter medial to the linea semilunaris. Cut the transversus abdominis muscle also without cutting the transversalis fascia. This is the transversalis fascia here. You should not cut it. Then you get into the space deep to the transversus abdominis, and you can then place a mesh there. And if you cut the transversalis fascia, there's a lot of additions and you cannot separate the two. You may have to do it sometimes, but if you do it, make sure that you don't cut the peritoneum. Peritoneum and the extra peritoneal tissue must remain intact. Otherwise, you have an issue. Now, that is the posterior component separation. And actually, when you do it, you can do it on one side if the midline defect is small. You can do it on both sides if the midline defect is big. But you can definitely get an approximation of a width of 10 or 12 centimeters. And that is possible when these component separation techniques are employed. All this can be done by open method, laparoscopic method, and of course, now the robotic method has come. I do not do a laparoscopic method. I continue to do open method in this, but perhaps I would take it up in days to come if I have the patience to do it. But they're all equivalent. And as I said, we have done some recent reading about it. There are no RCTs comparing, open versus laparoscopic or robotic. Most of them are retrospective studies which have shown equivalence of the different methods. Laparoscopy claims to be less painful, and that is to be accepted. And recovery, I don't think, is any faster because the patient has a major shift of the structures. Laparoscopy takes much longer than open surgery, perhaps more expensive because of the longer operation time that OT is being used. But in terms of recurrence rates, if you have it in single digits, if you have it below 10%, you're doing very well. Okay. Complications, just a recap of what we had done. Respiratory compromise is something you have to have in mind. After a component separation or AWR, I always keep them in the ICU overnight. I never send them to the ward. ACS is a possibility. Seroma and hematoma, there's a wide area of dissection. So one should expect hematoma or seroma, but be careful with your hemostasis. Infection, I mentioned this, DVT and pulmonary embolism. Ileus and obstruction are also possible. So you have to be careful when you start feeding them the post-op phase. If you have a small ventral hernia, we feed them the next day and send them home. But in all ACS, in all AWR cases, you've got to keep them in 2-3 days, make sure they're comfortable before you send them home. Okay, and I think that's my last slide. Thank you very much. I rushed through the last few slides because a lot of it was repetition. I do hope I gave you a clear idea about the anterior and the posterior component separation. If you have any questions, doubts, or comments, you're most welcome. Students first.
Sir?
Go on.
Sir, comparing with this polypropylene mesh with the composite meshes,
yeah,
you are advising polypropylene mesh because it has same complications as composite mesh or composite?
Complications are the same, but it is perhaps 1/10 the cost of a composite mesh.
Okay, yes.
Yeah, cost is the only thing.
So adhesions are same in both?
Adhesions and other things are all the same in both.
Okay.
Sir, in the loss of domain hernia repair, like how we talked about insufflating, like basically increasing the volume of the abdominal cavity.
Yes.
Instead, can we not do multiple staged procedures? Because when we insufflate the gas, the patient has to somehow tolerate that kind of a distress. So
how do you mean stage?
Like a part of it.
Reduce a
Not
part of the bowel and then go in again to another part. Doesn't really work, okay? Because you can't reduce a part and keep it there. You have to either reduce it completely or leave it. But I've done, as I said, I've done at least 7 or 8 of these and they tolerate it very well. There is no problem at all. No problem.
Okay. Okay.
All right. Srikanth had a question to recommend a textbook. Srikanth, particularly in things like this, AWRs and all that, textbooks don't give you enough information.
Yes.
Because it is, textbook information is considered 3 to 5 years late.
Years older.
Yeah. So I always look at references. And I've told this to my students also, any question I have in surgery, the first thing I do is look at stat pearls. So if you put in Google, regular Google search, you put a term, say, anterior, AWR, for example, okay, abdominal wall reconstruction. It'll come up with a lot of references. Some of them are for lay people, but you look for stat pearls, something that says stat pearls. And even that is not very extensive, but it gives you a very nice summary on the subject, on any topic. Okay, it gives you a nice summary. And from then on, I go into PMC, that is PubMed Central, and I type in various aspects. For example, AWR and complications, AWR and methods, AWR and definition, and things like that. When you do that, it'll keep on giving you a lot of full text articles, which you can download free of cost. I read them up. I at least have, as you can see from my presentation, 7 or 8 references. I read them all, full text articles. Before I prepare my final PPT. It's a lot of work, but it's well worth it. I don't expect the students to do all this kind of, at an MS DNB level, they can't do it. At an MCH level, they have to do it. But they have to read the stat pearls. And there are also, I saw somebody put it up, to a lovely, concise thing for postgraduates. The Maulana Azad Medical College update. Okay, I had it earlier. Somebody else put it somewhere, but I saw it even in our WhatsApp group. If you look at that, there are 2 chapters on this, on difficult abdominal hernias, and I read that also. So my advice: always read stat pearls and read at least one comprehensive article in PMC on all the important topics. Okay, so comments from Srikanth, followed by final comments from Ravi, and we close.
Very nice topics. Nothing to add. Current talk.
Yeah. Ravi?
Thank you.
I think. Yeah, Vinod, you had something?
Sorry, Vinod, tell me. Yeah.
No, sir. Ramakrishna sir is there.
Oh, I didn't see Ramakrishna. Welcome. I don't know. I didn't see you join. When did you join, Ramakrishna? Most welcome. Sorry about that. I didn't
joined little late, sir. I came from
Okay.
Uppidi little late. By
Okay,
9:30 I joined.
Okay. Your comments, please, before we go to Ravi. Yeah.
It's a nice talk, sir. How do you approach this posterior component separation, sir? From midline or from the lateral side?
Yeah, I see. When you have done the excision of the sac, for example, you are left with these 2 very laterally separated rectus muscles. Their posterior sheath will be intact. So you cut on to the posterior sheath. Okay, cut on to the medial edge of the separated rectus. You reach the retrorectus space and then push the rectus muscle away. The posterior rectus sheath is underneath you. Rectus muscle is above you, and keep pushing it away with your pledlet or whatever. You reach the linea semilunaris, the lateral border of the rectus, where the internal oblique has split, and consciously be 1 centimeter or 1.5 centimeter inside that area of the split, linea semilunaris, and cut onto the posterior rectus sheath in one part. If you do that, you see the transversus abdominis muscle, and I usually use a right angle forceps, pick up a little bit of the muscle and cut it, pick up a little bit and cut it in layers so that I don't cut the peritoneum and the transversalis fascia underneath it. So when you cut the muscles, then you have one little window. From there, you can be a little more cavalier and cut the whole length of the rectus sheath. And when you do that, you can then get underneath the transversalis muscle, and this, like you push the rectus away in the middle part. When you go lateral underneath the transversalis muscle, push that away as well, put that muscle away, and you find that the medial part of the posterior sheath keeps coming towards you, and you can actually get easily 5 to 6 centimeters on each side. So a 10 centimeter defect can be bridged.
So how far away? Means if the defect size superior inferiorly, if it is about 4 centimeter, how much of separation is required? Means more than the defect size.
4 or 5 centimeters is not a problem at all. You just need to, you can cut from the costal margin down to the suprapubic area. I usually at least use 2/3 of this in these bad incisional hernias, lengthwise.
2/3.
Yeah.
Yes. Is there will there be any bleeding when you are cutting this?
Yes. If you're in the wrong plane, you can have bleeding. So you have to, when you have bleeding, you must realize that you're in the wrong plane. And so stay in the right plane, correct your plane so that this happens when there is a lot of fibrosis in previous infection. Try and stay in the right plane, get hemostasis. Yeah, it takes time. That it takes about 3 hours or something like that to do this. And, as I said, hematoma is one of the complications. So one has to be careful.
So mesh goes beyond the linea semilunaris after
Yes.
defection.
After you close the defect, the mesh goes beyond the linea semilunaris.
Beyond that. Yes.
Yeah.
Yes. Thank you, sir.
Please post a video, sir, if you have it.
I don't have a video, unfortunately. I've done this open surgery. It was not. I don't do laparoscopic. I don't do laparoscopic AWR because it's to me it's tedious. So I have not. Next time I do one, I'll definitely get a video. Yeah. Okay, Ravi, your final remarks, and we are done. Yeah.
I think it was a succinct and comprehensive, disposition of abdominal wall reconstruction. I think it is a field that is growing, and slowly the data is accumulating. I think it is, as postgraduates, I think you should know about it. As Sir said, it's difficult for you to understand the nuances right away, and obviously will not be expected to answer the very in-depth questions about it also, and will not be expected to do it straight away and should qualify. It does need experience for you to get to this stage of doing it, but I think the principles have been well enunciated. Thank you very much. I think only one point. I think everything you have covered. The CT, when you request a CT for the AWRs, when there is LOD especially, they have to take thinner sections. Apparently, normally they take 3 mm sections. You should go even thinner, apparently, to try and get a much better all the aspects that you had listed out. They can be better appreciated if you do thinner sections. That is what the person who does a lot of these LODs, Shailesh, his name is Shailesh something from Mumbai, it's from Surat. So I heard him, and he took a lot of time to explain that. I think that is one message that I wanted to give. Thank you, sir. Good night.
Thank you very much, and good night.